My name is Ioana-Irina Rezuș, and my PhD topic is about the management of pancreatic cancer from diagnosis to treatment. I'm a second-year PhD student here at CTM Semmelweis and also at home at Grigore Popa University of Medicine and Pharmacy in Iași, Romania, and a radiology resident. My vision is to have better management for patients with pancreatic cancer, and for that my mission is to assess new diagnostic and treatment methods and implement them into healthcare. I have two ongoing projects. The first one started in September 2023 and the second one in December the same year. And the first project is about the efficacy and safety of therapeutic procedures for chronic pain in patients with unresectable pancreatic adenocarcinoma. Pancreatic adenocarcinoma is currently the sixth leading cause of cancer-related death, but it is expected to become the second one by 2030. Almost 80% of these patients are diagnosed with unresectable disease, and almost as many have pain from the point of diagnostic. Unfortunately, the opioid treatment, which is the most used one, is still associated with inadequate pain relief in more than half of these patients. However, there have been emerging more interventional ways to address this pain, and our aim is to find the most efficient one of them that currently exists for treating adult patients. We phrased the question which method is more effective and safer for pain management in patients with unresectable pancreatic cancer, with the population being adult patients, interventions and comparators being any kind of pain management. Primary outcomes were pain relief and quality of life, while secondary outcomes were adverse event survival and analgesic drug use. And we decided to include only randomized controlled trials. Our hypothesis was that interventional methods can provide a better care for these patients. We made a search key with 4 domains, one for pancreas, one for cancer, one for pain, and one for only randomized controlled trials. And in the brackets, you can see the number of hits on each database. We started with around 5,500 articles, and after the selection, we ended up with 21 eligible full-text articles. We have results for all of our outcomes. However, I will show you some results for the pain and the adverse event outcomes. First, about the pain. Here you can see the pain results at baseline in all of the included studies. Pain was measured on the visual analog scale, which ranges from 0, meaning no pain, to 10, meaning the worst pain possible. You can see that we have more study groups. Most of them are one-time interventions, such as different types of celiac plexus neurolysis, endoscopic ultrasound-guided, intraoperative, or percutaneous, and high-intensity focused ultrasound. And then there is the opioid group, which means a continuous treatment of daily opioid intake. When we look at the baseline values, we can see that in all of the included studies, the baseline pain values were around 5 to 6 on the VAS scale, meaning a moderate to severe pain. We were curious to assess the dynamic of this pain from the point of the intervention and at different time points. So we measured this pain at 0, 4, 8, and 12 weeks after intervention. And we can see that at 4 weeks, in all of the study groups, the pain significantly decreased. However, there is no significant difference between the interventions. Then at 8 weeks, this pain starts to slowly increase, but again, there is no difference between the intervention groups. And this pattern follows at 12 weeks too. We could say that at 12 weeks, the endoscopic guided celiac plexus neurolysis performed best. However, because of the low number of studies included, we can't draw a definite conclusion. It's important to mention that also the analgesic drug use followed the same pattern with the pain, while the quality of life followed the mirroring effect, that the quality of life increased at 4 weeks, but then started to slowly decrease at 8 and then 12 weeks. When we talk about the adverse events of these procedures, the most cited adverse events were gastroenterological and cardiovascular. It is important to mention that these were defined as transient adverse events lasting 3 to 5 days after intervention. And when we compare the percutaneous to the endoscopic ultrasound-guided celiac plexus neurolysis, we can see that there were bigger chances for diarrhea, nausea, and orthostatic hypotension in the percutaneous group. When we look at the opioids, as it was expected, the chances for nausea, constipation, and vomiting were, of course, higher after opioid intake. To conclude, we could say that minimally invasive procedures provide pain reduction with fewer associated adverse events, and out of them, the endoscopic ultrasound-guided celiac plexus neurolysis had a better overall performance. This is important for practice because these procedures should be considered more often and earlier in the management of these patients. And for research, it is important that we have further RCTs that compare not only one intervention to the opioid or to the standard of care, but also that they will compare different interventions between themselves, and also one-time intervention with multiple repetitions of the same intervention. The strengths of our study are that we included a large number of procedures, and we wanted to analyze different time points, and we could include only RCTs. However, there was a high heterogeneity among these RCTs. The total number of studies was low, and the analyses were complicated because of a lack of gold standards for pain and quality of life assessments. At this point, the manuscript is written, and it is under revision with the Translational Gastroenterology and Hepatology Journal. My second project is about the diagnostic performances of different imaging techniques in pancreatic cancer diagnosis. As mentioned before, pancreatic cancer has a very poor prognosis, with resection being the only chance of cure. It is highly important to notice that even if the 5-year survival rate has an overall of only 4.6%, when we look only into the tumors smaller than 2 centimeters, this 5-year survival rate raises to 80%. So it's very important to diagnose as early and as correctly as possible these tumors. And the techniques that are most commonly used are the imaging ones, such as CT, MRI, or endoscopic ultrasound, and our aim is to find the best performing out of them. We phrased the question, which imaging technique has the best diagnostic performance for pancreatic cancer detection and staging, with, again, the population being adult patients. Interventions are the radiological examinations that are compared to the reference test, that is the pathological examination, and the outcome is the performance of detection and staging of pancreatic cancer. Our hypothesis is that one investigation provides better results compared to the others, and the clinical implication, the most important one, will be an increase in the survival if these tumors are found earlier. And for the policymakers, it's important to decrease the number of unnecessary investigations. Again, our search key had one domain for pancreatic cancer, one for the imaging tests, one for the diagnostic and detection, and one for randomized controlled trials or directly comparative trials, because we wanted to include only the studies where every person from the population underwent all the analyzed imaging techniques. And in brackets, you can see the number of hits. So we started with more than 21,000 articles and ended up with 90 eligible full texts. At this point, we just finished the data extraction, and the data are with our statistician now. In summary, I have 2 ongoing projects. The first one is submitted to the journal, and I plan to submit the second one by this autumn. I thank you for your attention, and I leave you with the words of George Bernard Shaw: don't wait for opportunity, create it.
Wonderful presentation, Irina. Congratulations.
Thank you.
Could you give some comments on the first study regarding the pains? What can cause the pain to increase after the intervention, and would it be worth to give another intervention to the patients to cause again a decrease in pain?
The problem is that pain in pancreatic cancer seems to be very complex. So if the tumor invasion is high, then this pain can reappear. There are studies that suggest that if these interventions are performed earlier, maybe this effect can be prolonged. Some authors argue that they should also be repeated. However, I couldn't see trials where they really tried to repeat them. Another idea would be to use more interventions and to somehow combine them, to do neurolysis and then HIFU and so on. But I believe that, as Ioana said, that the survival increases in patients with cancer, and then we should focus on their quality of life. So I think there is a need to answer these questions.
Thank you. Any other questions?
I was surprised that the number of the RCTs on EVS-guided neurolysis is so low. Do you have any comments on that, or did you investigate the cause of this phenomenon? Because probably it's so obvious that this is a good method for pain relief, or what
Yes.
can be the reason?
I am not sure. There were many observational studies and cohort studies, but the number of RCT was not necessarily low, but lower than we expected. I am not sure what could be the cause. But the articles we included are also from multiple countries. We didn't put any restriction on our search, so this is just the available literature.